Hey everyone, and welcome to the Balanced Bodies Blueprint. I am your host, Vinny Russo.
And I'm your co-host, Dr. Erin Stansfield.
And we're shifting gears from all the conventional fitness narrative you hear on most fitness podcasts, as our main emphasis lies in preventative healthcare, adopting a holistic approach to nutrition, and challenging the traditional views on various fitness topics.
Our mission with this podcast is to provide you with the information you need to achieve optimal health.
And on today's podcast, we have a very special guest who is going to lead us on an exploration of eating disorders, and his name is Dr. Marc Ybaben. So, Dr. Marc, thank you so much for taking some time to actually come in and explain to our listeners about eating disorder. But before we actually dive into those eating disorders, can you just give us your background and let our listeners know, your qualifications and everything, your schooling, all of that, so they understand, where they're actually getting the information from?
Sure thing. And I appreciate you both having me on today. So thank you.
Of course.
So I am a clinical psychologist, and I've been doing this for a while. I started off professionally, actually in the Air Force as an Air Force officer psychologist, and I was in there for about 5 years. And during that time, I specialized in something called clinical health psychology. So it's a specialty area in psychology that works with mostly medical patients. So I was often in a medical facility, hospital, or medical clinic. And in health psychology, you learn to treat people who have migraine headaches, chronic pain conditions, heart conditions, diabetes, et cetera, anything health related. Which also leads into things like substance abuse, alcohol and drug problems, eating disorders, which of course we'll talk about today. Again, anything related to health. And just to kind of be clear with that, I know a lot of people, kind of half joke or actually seriously think about, oh, you're saying something's in my head, you're saying I'm crazy or whatever because I have headaches. And of course, that's far from it. But the majority of medical conditions certainly have psychological components. And by that, I mean anything to do with behaviors, our moods, our thoughts, our relationships with people. All those things are psychological. And so a whole host, if not all, you might argue medical conditions have some kind of psychological component. So in health psychology, we learn how to help people with, again, any number of medical sort of problems, health-related problems. And I did that for several years and still do a lot of health work. After the Air Force, I did some private practice work. I was a graduate professor, doctoral and master's program professor, and did a lot of organizational and leadership consulting as well. And then almost 15 years ago, I started my current position, which is in an occupational medicine clinic. So again, a health-related place. It's a workplace clinic, so dealing with a lot of workplace situations, illnesses, injuries, etc.
Awesome.
And that's how we met, right?
Yes. Thank you.
I've worked with Dr. Ybaben for the past 13, 14 years.
Yeah.
And he is in a very clinical setting because he's in my clinic, and have gotten to know him very well. And he neglected to mention that he actually used to teach. So this is kind of his wheelhouse of education.
Yeah,
so
I like
think
teaching.
It's great
it's fun.
to have him on. Yeah.
Yeah,
Well,
especially,
thank you.
having that educational background, being able to explain complex information to someone who's not very familiar with it. So this is going to be really good.
Cool.
So yeah, let's dive in it. How do physicians or providers actually diagnose an eating disorder in general?
Well, the physician side, of course, Dr. Stansfield could give us more on that. But in general, diagnosis can be any combination of evaluations, medical evaluations. Certain labs can give a lot of information, of course, on how the person's doing. On the psych side, it would mostly be in the form of interviews and maybe psych testing of some sort, just to get at what's going on. In general, I mean, any diagnosis, and again, in mental health side of things, is really a pattern of symptoms. And so we're looking at thoughts and moods and behaviors, how they come together that create some kind of problem in the person's life, whether their social life, their health life, their occupational life. So again, any number of symptoms that are impacting them like that.
Yeah, and it's funny too because like now, like on social media, there's a lot of these ads that are like promoting these. At least I've seen a few, and maybe it's
Mhm.
based off the algorithm, but it's like take this quick quiz and find out your childhood trauma. And I'm like, is that really going to tell me? Like, are those accurate or?
What Disney princess are you? I don't know. You know?
Yeah.
Yeah, I mean, I don't. Those are fun, and that's about
Yeah.
as valid as they are. They're not going to have a whole lot of research behind them, most likely,
Mhm.
uh, to show if they're actually accurate or reliable, etc. But I'm a snob with that kind of stuff. So
He
so
does a
we
lot of testing, so
Yeah.
he's
yeah,
very good at
I
that.
have the
Yeah.
legit tests, and so they're expensive. Only certain people can actually get them
Yeah.
and purchase them. So that's the legit side of things.
Right.
But yeah, there's a lot of stuff out there, that's for sure.
Yeah.
Yes. Yeah. Well, let's jump right into it. Let's
Sure.
talk about some of these eating disorders.
Okay.
So the first one on the docket looks like we have is binge eating disorder.
Okay.
So can you kind of tell us what the DSM-5 criteria is? How, what kind of characteristics are you looking for with somebody who might be diagnosed with something like this?
And
Sure.
also, can you tell
Yeah.
us what the DSM-5 is?
Yeah, I was going to do that. That's fancy language. So the DSM-5, it stands for the Diagnostic and Statistical Manual of Mental Disorders, and it's the fifth edition, hence five. There's
Mhm.
actually a newer, uh, a slightly newer version, but we just still call it the DSM-5. And it's a big, thick book, and it has all the mental disorders listed, all the criteria for the disorders. It's an interesting book. It's a fun book, I guess you could say. You could bring it to dinner parties and
Yeah.
diagnose each other or something. It's kind of fun. And it's put out by the American Psychiatric Association. And certainly in the United States, that's the main thing that's used for diagnoses and for insurance companies. When a provider sees someone, they have to, assuming they're being paid by insurance or partly paid by insurance, this is the kind of diagnosis or the system that's used that we share with the insurance company. So we say, yep, here's the diagnoses, here's the code, blah, blah, blah. And that's how things get paid, get taken care of. So,
Yeah.
and it's used certainly in other countries around the world, actually. So it's kind of one of the standards. So in the DSM, binge eating disorders, go through several of the criteria here. So first of all, it's recurrent episodes of binge eating, and binge eating is eating a lot of food, more than you would usually eat.
Mhm.
Okay, there are ways to kind of categorize that, but we're eating a lot of food, again, larger than usual, and the person has a sense of a lack of control over their eating. Okay, so they're eating a ton of stuff, and of course, like you'd imagine, it's not. They're not saying, "Oh, I just had 5 apples." Yeah, no, that's not. That's maybe pretty good. That's maybe another condition we'll talk about, but it's usually going to be something that's not super healthy for you. A
Highly
bag.
palatable, highly processed, highly palatable.
Yeah, absolutely. So bag of chips, a big carton of ice cream, a bunch of cookies, etc. So not great stuff, but again, more than you would usually eat. The episodes also have several things going on. The person's usually eating faster than normal, so they're kind of wolfing it down.
Mhm.
They're probably going to eat until they're uncomfortably full, and they're going to eat all this food when they're probably not even hungry. So again, they're eating a ton, not even hungry. They're often eating alone, probably because of embarrassment or shame. Even they know they're eating a lot, and then afterwards they might feel disgusted with themselves or depressed or guilty afterwards. So a lot of these kind of negative sort of emotional experiences. Um, and they're going to have some distress over that. That's one of the common criterion for all disorders. Something's going on, and they're feeling distress about it. it's not cool with them. So
Yeah.
um, so that happens, and it happens at least once a week for 3 months in order, as part of the diagnostic criteria. Um, so that's kind of the main stuff that's going on. Yeah.
Yeah, and so you said in terms of like how long they have to binge for, you just kind of
Hmm.
mentioned it has to be over,
Yeah.
like it has to be more than 3 months, one episode.
Yeah. At least once, one of these episodes a week for 3 months.
Okay.
And that's important because, other things, some people will say, oh, I had whatever, I ate a pizza. I must have binge eating disorder.
Yeah,
Like,
yeah,
no, that's just,
That's a one
one
time.
episode.
yeah,
That's a
Yeah.
one-time thing. Or even with other disorders, if someone had a panic attack, for example, that doesn't mean they can be diagnosed with what's called panic disorder. Panic disorder is again a pattern of a whole bunch of things, including kind of regular panic attacks. So similar thing with these eating disorders. Again, one binge episode does not by itself mean anything.
yeah. And I just want to touch on too, because we were slash are competitors.
Mhm.
We
Yeah,
we have friends that are, we've been in the business, we know what that's like, and there is a lot of binge eating episodes. And you mentioned
yeah.
something like not eating because of not eating when they're hungry. Do you think it has more or less to do like if we're looking at over restriction, which is what competitors do,
Mm.
to where it's very, very structured and they don't veer off the plan because you literally have to get to that condition. Do you
Right.
think it's more of like having the opportunity to do some, if even if they're not hungry, it's just like it's there, it's the opportunity, or do you think there's something going on, something more going on there?
Yeah, it's a great question. I think there's, and this goes, I think, with all the disorders we'll talk about today. There's a real cyclical part of this where, they're feeling something. Maybe they're starting off feeling kind of bad, kind of down, or something, whatever about themselves, about their appearance, or what have you. And so then they eat and they feel better
It's a dopamine response, right?
temporarily. Sure,
Mhm.
yeah, sure, yeah. Lots going on. So they feel better. Oh, good. It's kind of a relief, but then they feel bad.
Yeah.
So then they eat more, and then they feel good. Then they feel
The
bad. Then they
vicious
feel good.
cycle.
Yeah,
Yeah.
absolutely. So that's what happens a lot of times, and again, that kind of pattern comes up with a lot of these disorders.
Yeah, and you see it even with some of our clients that have been through this in the past. Like
Hmm.
I've been coaching for over, 13 years,
Yeah.
and they would punish themselves after a binge, like maybe it's a binge night,
Hmm.
and they wake up and they do fasted cardio for like 2 hours, and then they work out right after it because they feel guilty, and it's a
Sure.
form of punishment, and that only
Yeah.
builds an even worse negative relationship with food.
Absolutely. Absolutely.
Yeah.
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 I was going to ask you,
Hmm.
based on, some of the criteria you've given, do you see other disorders commonly presented with binge eating disorder? And then also if maybe you can touch on what to do if you suspect that you have something like this. How do you stop this cycle?
Yeah. Great questions. So I think a lot of these eating disorders that we'll touch on have a lot of the same comorbid conditions. So bipolar disorder, which a lot of people remember manic depression. That's the old term that was used. So these up cycles and down cycles at different times. So bipolar disorder, depression or major depressive disorder is the official kind of title, and a number of anxiety disorders, including obsessive-compulsive disorder. Those are all pretty common with these eating disorders.
Wow.
And so you see a lot of that often with the treatment part because, as you can imagine, um, these disorders are very unhealthy for the people, including we'll talk about anorexia here in a minute. Um, they can kill the person, right? I mean, they're pretty serious. They're
Mhm.
seriously unhealthy. And so a lot of times in treatment, even though there may be several of these disorders going on, they'll probably treat the eating disorder first, just to make sure the person's healthy and
Yeah.
stable. And then, okay, great, now let's work on this other stuff. So there's kind of a stepped approach a lot of times.
Yeah.
But anywhere 30, 40, 50% of the patients with eating disorders have some of these other disorders.
Yeah, I was going to say
Yeah.
there's usually presence of anxiety or some other
Hmm.
comorbidities, as you mentioned.
Yeah.
What about any genetic or potential epigenetic factors in these
Yeah.
disorders?
They tend to and binge eating first maybe they tend to run in families. So if you have one, probably, and I didn't mention this at the beginning, but just kind of a reality check. The in the United States, at least, the majority of the patients we're talking about are young girls and women.
Yeah.
Okay, it's like
Mhm.
10 to 1, 12 to 1 with women and men having these disorders. So a lot of the studies out there are just with women or girls, adolescent girls. If they have men in the studies, it's 400 women and 50 guys or
Yeah.
something. So again, it's pretty skewed in that way. So I'll just kind of talk about women probably. So again, with the genetic part, if maybe mom or sister or someone else has this kind of disorder, yeah, the other sister or daughter or someone might as well. That's always a risky kind of topic in some ways with a lot of these psych problems, I think, in that I've heard people, I see a lot of people who say, well, it's, whatever, eating disorders or alcohol problems, etc., bipolar disorder. Well, it's genetic, and like they kind of throw their hands up, like there's nothing to do about it because it's genetic.
Yeah.
And it's like, no, 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 hold on.
Yeah.
There's a lot we can do. We'll talk about treatment here, but there's a lot we can do. Just because there's a genetic component doesn't mean you're powerless or there's nothing
Mhm.
to do again or something like that. So, yep, there are some genetic ties, but there's
There's
all sorts of
treatment.
help. Yeah.
Yeah.
Gotcha.
Yeah. Now we touched a little bit on like the aspect of women versus men.
Mhm.
When it comes into that, is there like any early life stressors or is there trauma, especially like with little girls and maybe like, I don't know, their social acceptance maybe that contributes to having these disorders?
Yeah. Not with trauma specifically, not a whole lot or not necessarily any clear path. Um, uh, I think more so maybe with bulimia and anorexia, we'll talk about kind of life stressors or something that might get them going.
Yeah.
Going away to college. Oh, that's stressful, and the person starts getting into it. Um, with some binge eating and bulimia. Um, they might start off being, kind of overweight or something, and so having some just kind of normal body issues. So,
Mhm.
a young girl who's overweight, well, now I want to start, I'm uncomfortable now. I want to start doing something to, help myself somehow.
Yeah.
So not necessarily, again, trauma. There wasn't, I came across an interesting study by the VA, the Veterans Affairs, looking at female soldiers, airmen, veterans, etc., female military population who had diagnosed eating disorders, binge eating, anorexia, and bulimia. And interestingly, or frighteningly, I guess, um, the the kicker for them was military sexual trauma, more so than military combat.
Oh, wow.
So that some of them had combat, and you'd expect PTSD or something, and but more often they had a history of military sexual trauma, and Dr. Stansfield knows in the military setting there's a whole there's an office, a big program, lots of help for people, both men and women, who have any kind of sexual assault that occurs at work or related to work or something. Um, but again, a good portion of them had military sexual trauma, but that again is a very specific population. In general, again, not really a trauma connection, so to speak.
Huh, that's an
So,
interesting study then,
yeah,
it sounds like.
yeah.
What about any sleep disturbances related to this?
Um, I mean, in the sense that if you have problematic eating and moods, and again, especially if you have depression or anxiety problems, kind of on top of that, and again, with the health part of eating disorders being a problem, they're probably going to have some sleep problems. It's not going to be what we call primary insomnia, which is, insomnia is the main problem, or some other kind of sleep disorder. But they're probably going to have some sleep problems. Most people who aren't so healthy and have these other, mental health disorders, yeah, sleep's a symptom.
Right.
So
Right.
yeah,
It
so
almost it almost feels like a three body problem because it's like one thing affects another thing, but that thing can
yeah.
affect this and then another, and it's just like they all could play a role with each other.
Absolutely, definitely, and that's, I think, a lot of, especially these health related conditions. It's such an interactive process like that,
Right.
because one is linked to the other, et cetera. And so again, that kind of thing is addressed in the better treatment settings. So we got to fix everything going on here. There's a lot going on.
Yeah.
Let's tackle it. So.
Yeah.
Do
No.
you, sorry, I don't mean to cut you off, but do you take it like we're focused on one thing at a time, or do you try to couple some things that are like closely related when you try to treat them?
Yeah, usually it's going to be a combination of things. Some address the behavioral, the eating part, or the binging part here, as well as these ideas. And again, just focusing on binge eating for now. The lack of control. I have no control over this, kind of a thing, and I'm don't like how I feel, and I'm depressed, and I'm guilty. So you're going to be working with a lot of those things simultaneously.
Yeah.
And does treatment revolve mostly on behavioral changes, or are there any medications? Can you talk
Mhm.
about the treatment a little bit?
Yeah, sure. And as bad as some of these disorders sound, and they are very serious again, I'm a realistic optimist. There's a lot of good treatment out there, so there's effective help for anyone working with this stuff. The trick, and maybe we could talk about this at the end. The trick is finding the right program or the right person to get this highly effective treatment.
Yeah.
So, um, so again, with binge eating, there's strong support for a couple different treatments, both individual and group based treatment. One is called CBT. We call it, it's cognitive behavioral therapy. Psychology people like using, little acronyms like that. So CBT, cognitive behavioral therapy. And a second one with strong research evidence or support is something called IPT, which is interpersonal psychotherapy. Okay. IPT is actually something that started with depressed patients. And so it's highly effective for that. But then they started using it for binge eating, and sure enough, they found that it's also effective. CBT is a type of treatment that focuses on a few different things. The cognitive part, this thinking process part, whether it's, I have no control, well, that's a thought,
Mhm.
or I'm a horrible person, okay, that's a thought. No one cares about me, or I'm fat, or whatever. They have this kind of distorted thinking that will lead them into the unhealthy behavior. So I'm out of control, so I might as well do this, or something's wrong with me, so again, I'm just going to do this. Who
Mhm.
cares? I'll keep doing this. And so the cognitive part is addressing those what we might call distorted thoughts. They're not helpful thoughts, certainly. They're not even reasonable thoughts sometimes. They're distorted somehow. Let's change them to thoughts that might make more sense, or at least are more helpful for the person. A lot of times, the thoughts, of course, certainly sound negative when they're
Mhm.
struggling with the disorder, and they are. They're negative. Um, and sometimes when working with a person with CBT, a lot of times their first reaction is, "Oh, you just want me to think positively, power of positive thinking," or something like that. And I'll tell them, "No, no, I don't want you to think positively. Because that's this real kind of extreme thinking, this black and white sort of thinking, is actually something that occurs already in these disorders. It's
Mhm.
all bad. I have to be perfect. I have to be, look a certain way, blah, blah, blah. So they're already thinking in these really rigid terms. And so, no, we don't want you to think, again, black and white. Let's think something, hey, it's plus or minus in the middle. I'm not the worst person in the world, but I'm okay. I'm a halfway decent person, or
Yeah.
some people are okay with me. Um, And so we're trying to think more flexibly, more again, kind of in the middle, so to speak, not positive, negative. That's the cognitive piece, and again, kind of simultaneously, we're working with a lot of behavioral principles. Again, watching out for the eating, shifting the eating, um, the all these the other kind of behavioral things, the eating alone kind of stuff, and the fast eating. So we'll help them slow it down and do some other things. Again, working towards just healthy behaviors,
Yeah.
and a good program, or maybe um, a pretty inclusive program. We're going to have exercise people and medical people and nutritionists and all sorts of different. It's going to be a multidisciplinary piece to really address all these different factors with the person.
Mhm.
So again, a lot of that comes out of CBT. IPT, the interpersonal therapy, that's a type of therapy that focuses on relationships. And at the beginning, of course, on the maladaptive or dysfunctional sort of relationships that a person has, maybe with other family members, if they have a romantic partner or even certain friends. What we know is when those relationships start kind of clearing up and getting healthier, then in this case the binge eating starts changing. The person feels okay, they're supported, they have good relationships with people. There are fewer needs, so to speak, to engage in this unhealthy behavior. Again, if we have a decent relationship, well, that we start feeling okay about ourselves, we're not so guilty, we're not so depressed, etc. And so again, just focusing on relationships shifts some of this behavior. So,
That's awesome that you just said that, because I mean, I would never even thought of that, because we do have
yeah.
clients that come on that are married and they're like,
Mhm.
I want to do this. I got to talk about it with my spouse. They really don't support me.
Yeah.
And well, they're
Yeah.
coming to us for help to lose weight, and maybe they are binge eating, and it could be because
Mhm.
of the lack of support. Like
Sure.
that didn't even cross my mind. That's pretty crazy.
Yeah.
Yeah.
I didn't even realize the CBT component of the extreme thought process, like all positive or all negative. So I
Yeah.
think that's an
Yeah.
excellent
Yeah,
point too.
and touching on that, like, because you have some dichotomy here, right, with
Mhm.
the good and bad. So,
Yeah.
and there's no gray area. So, do you try to just like step them into that? So it's like, I'm fat, so let me just eat my face off, to I'm fat, but I'm gonna work on myself. Does it like that, or
Sure. Yeah. And even the fat term that you're using, well, that's kind of a judgy term.
yeah?
Yeah.
Oh, okay. Yeah.
Versus, well, I am overweight. I
Yes.
can, I could actually, check it out. Yeah, but technically I'm overweight. All right. Well, that's not, the end of the world or something. I'm
Mhm.
not a horrible person just because I'm overweight,
Yeah. Yeah. Yeah.
Yeah. That's interesting.
etc.
Yeah.
Yeah. Because
Yeah.
I feel like we come from a world of very black and white,
Mhm.
especially working with
Yeah.
competitors, right? That
It's
are
all or
Oh,
like,
sure.
nothing. Yeah.
it's
Gotta
all
go,
or
gotta
nothing.
go.
Yeah.
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 Right.
So it's
And
kind of an
there,
interesting thought process.
yeah, and of course there are situations where going really hard makes sense and
Yeah.
can be helpful and functional.
Right.
But if it's too much, without some kind of balance or back and forth or something, then
Yeah.
the person can get stuck like that.
I feel like if it's
You,
disrupting your life,
right?
it's
Yeah,
bad.
exactly. Yeah, right. Back to the diagnostic part. Yeah, if it's creating some problem in your life, well, then it's a problem.
Right.
So yeah,
Exactly. Yeah.
you mentioned medication. Also, medication's interesting with binge eating. Um, there are some studies with certain antidepressant medications like Prozac. That's a common one that's prescribed. Prozac compared to like CBT is not so great. It's not as effective by itself. I should
Right.
say Prozac all by
By
itself
itself. Yeah.
with no other treatment is not super hot. In combination with other things, it gets better. Interestingly, um, Vyvanse, which is an
Oh,
attention
interesting.
deficit, yeah,
Yeah.
an attention deficit medication. The chemical name is some big crazy name I can't say. You
We'll
probably
say
know.
by Vance.
I'll just say Vyvanse, yeah. And that kind of medication, like a lot of other ADHD medications, it's a stimulant.
Mhm.
And again, stimulants are tricky, especially with weight stuff. I'm sure you two
Right.
know about stimulant use and overuse.
They can suppress your appetite.
Yeah, and so it's often a part of an eating problem or a weight control problem or something, or it can be. But the Vyvanse seems to kind of take away some of this kind of obsessive behavior and focus, and it cuts back the binging behavior a bit too. So there's some interesting recent success with Vyvanse. Again, more successful when it's a part of a multidisciplinary treatment program. Just giving someone a stimulant and saying, good luck with your binging is not real helpful. Yeah. So, but again, it's interesting. I think
it's a nice correlation to like what we see now with weight loss medications. It's like,
all
right, well, here's a weight loss medication, lose the weight, but good luck, like you need guidance, like they need guidance, they need help. There's more to it than just taking a drug.
Yeah, that's interesting. Just another note with the treatment stuff. I would not like to be a consumer in the mental health field. There are actually hundreds of different types of psychological treatments that are out there. Most of us in grad school learn like the top 10 and practice like 3 of them that we like. And of the hundreds of approaches out there, a lot of them are real fringy kind of stuff. And some of them are offshoots of legit stuff. But it's hard to know, well, what's really effective or not, because most of those hundreds have not been well researched.
Right.
Some of them, again, kind of the top 10 have been, but a lot of them haven't been. And who you go to, it's a coin toss. And you don't, again, kind of the general consumer, even with the help of the internet, the general consumer, that they don't know what's legit or not. They don't know who to look for, where to go, and so I think I feel for them if they're struggling with something like this and they want help. But again, I'll try to guide you a little bit at the end here.
I was just gonna say maybe you can touch on that at the end and give some resources.
And I was gonna say too, like when you said that there was like 2 treatments like that, like you would recommend for binge eating, I thought you were gonna say like exposure therapy, and you didn't, and I'm like, oh, okay, like good to know.
Yeah, that's a good one. And exposure therapy, that is a CBT or a behavioral intervention.
Treatment.
So it could be part of that, but that's usually used for fear-based sort of programs. Which, I mean, fear comes into play in some of these other disorders. But yeah, that is a good, and that's for a lot of things, that's highly effective too.
Well, let's go into some of those other disorders. Let's go into anorexia nervosa. So can you discuss that diagnostic criteria?
Yeah, sure. So again, just using DSM stuff. So with anorexia, there's a restriction of they call it energy intake, which usually means food, right? So
could be a drink, maybe.
That's true. Yeah, everyone
just calories.
The protein thing, whatever. So better a restriction of energy intake, leading to what they call a significantly low body weight. Okay, so not just someone who's thin or something, but significantly low. There are ways of defining that. The person with anorexia, and this goes to your exposure stuff, they do have an intense fear now of gaining weight or of becoming fat. So there's this worry that, oh no, it's I'm gonna gain weight, I'm gonna get fat, and fears, anxiety that's also saying it, and it's gonna be somehow horrible if I get fat or something. So that's this kind of worry stuff. There's also for people with anorexia kind of another distortion in how they perceive their body. So again, they might be very thin, 80, 70 pounds, whatever, and they'll look at themselves and go, oh, I'm so fat, or oh, look at my hips, or oh, look, whatever. I'm still fat, even though objectively, of course, you can see that now the person's extremely thin. Maybe they of course get to be dangerously thin at times. Now, interestingly, there are two different types within anorexia. A lot of times we think of these binging and bulimia sort of things as being separate, but they're well, kind of connected in a way. So one type is what they call the restricting type of anorexia, and the restricting type is where this rapid, or not rapid, but this weight loss is mostly through dieting, fasting, excessive exercise, those sort of behaviors. Again, not eating, exercising, etc. The second type is a binge eating, purging. So again, we're back to binging here. So binge eating or purging, in that type, they're losing the weight through a series of binging and purging behavior. And purging, of course, could be most people equate it with vomiting, but that's just one way. It could be vomiting or misuse of laxatives or diuretics or enemas. So again, they're anorexic, they're very thin, they're fearful, and again, they could do that either through the restrictive or the binging type. So it's kind of
it sounds like there's like a form of like another disorder in there, body dysmorphia.
Yeah, that's a different thing too. That's usually focused on maybe specific body parts, and not liking it. Like, oh, look at my biceps. They're horrible and they're ugly and they're disgusting and whatever. They're kind of focused on these different things, and it's a real hyper focus. Sort of disorder. Some of the criteria for body dysmorphia are, walking by a mirror, whatever, 100 times a day, and making comments about your appearance,
pinching your belly fat,
and doing that kind of thing, and then telling your friend at work, "Oh my God, look at how horrible this part of my body is," and things like that. So there's definitely a lot of overlap with these these body image sort of problems. That's for sure.
Interesting.
Yeah.
What about, is this disorder related, anorexia now that we're talking about, is it related to control? Because that's kind of the impression I get. It's like they have to control their food intake. And now I'm just wondering if that leads or seeps into other parts of their maybe lack of control in their lives.
Yeah, good question. So control is kind of a it's an interesting term that we use. If you just talk to someone on the streets, oh, my boss is such a control freak or something, or so and so, my spouse is a control freak, or they have control issues, right? People use that kind of terminology just kind of casually. And usually if someone, even if someone self-identifies, they come in, I have control issues. If you poke around at that and start, actually talking to them and exploring, what do you mean by control issues? They're usually talking in terms of anxiety or worry sort of experiences. Well, if I don't do whatever, such and such, then this bad thing will happen, that's anxious thinking. Gosh, if I have to do this or else, and you could hear that with OCD, with obsessive-compulsive disorder, which is a type of anxiety disorder. Well, if I don't wash my hands, for an hour, I might get someone sick at home, so I better wash my hands, right, for an hour, or wash the chicken, or check the outlet or something. So again, when people are controlling like that, again, it's often this kind of anxious, sort of thing. Uh-oh, something bad's going to happen. So that's just kind of control. Interestingly, the anorexia especially, and some of these other eating disorders are sometimes called disorders of over control. So kind of what you were pointing out, Dr. Stansfield, that there is some sense of I have to do something. Although a lot of the over control comes out maybe in interpersonal ways. They're socially isolated because again, when they're engaging in this kind of behavior, there's a lot of isolation. They're not super social or leading normal lives like that. But social isolation or loneliness, or again, problematic interpersonal relationships, going back to the IPT sort of treatments. And people with those kind of, got to have everything, a certain way sort of a thing, in general tend to have more severe mental health problems. So absolutely, there's certainly components to that in anorexia and again even some of these other disorders.
Yeah, and what about childhood trauma? I remember I was in college and
Mhm.
there was a girl that we all knew,
Yeah.
and she was open about, that she was diagnosed with this, but her main thing was like she saw the way her mother was as a
Hmm.
kid, and she never wanted to be like that. And her mother was very overweight, needed to be
Uh,
taken care of.
yeah.
So that was like her explanation to us. We don't know, I don't know if that's true or not, but does childhood
Right.
trauma like play to that, play to this disorder or?
Yeah, and just like with the binge eating, not necessarily, maybe not necessarily as a common predictor of anorexia. I mean,
Mhm.
yes, you're absolutely going to find, um, again, girls and women with some kind of history of trauma, who then develop an eating disorder. But more often, it's going to be, again, just like I mentioned earlier, just kind of life stuff. Life stressor, again, going to college, or maybe break up with someone in a relationship, or just some other kind of, just life stress sort of stuff.
Yeah, interesting. What
Yeah.
about, do these psychological factors like perfectionism, obsessive compulsive traits, maybe that you alluded to,
Yeah.
does that play into the restraint in anorexia nervosa, or what kind of psychological factors do you see?
Yeah, sure. Because again, one of the diagnostic criteria again was this fear of getting fat, and so there's still this worry component. Uh-oh,
Yeah.
that's the thing. Uh-oh. Um, I need to do this or else, this thing's going to happen, and if I eat, then I'm going to get fat, like your example, Vinny, just like my mom, and I don't want to do that. So, oh
Mhm.
no, I have to do this other thing. And it has to be a certain way. Again, that kind of over control thing certainly comes out, and I have to look a certain way, and I have to be a certain way, or else, because there's always this or else piece,
Yeah.
or else something bad. I'll be out of control. I'll be, what have
Something
you.
bad will happen. Yeah.
Yeah, and again, you hear a lot of that with this OCD kind of stuff, and it's really easy to again see this cycle that keeps happening. So I do it, and then something else happens, and then I'm sick, and then and person's life's falling apart. So I need to do it more to get control of this, and they just kind of keep going and going and going.
Yeah.
And would you say it's safe to say that like anxiety is like the foundation of what like all these kind of build off of?
Well, no, again, it's one of the anxiety in general is one of the comorbid, conditions, even disorders with all these eating disorders we're talking about here
Yeah.
today. Yeah,
Yeah.
so
Yeah.
it's there, that's for sure.
Yeah. And
Yeah.
just on the medical side,
Mhm.
this is a very dangerous disorder. And just to touch on the medical
Yeah.
complications, you can get things like hypotension, bradycardia, so your heart slowing down. Um, Women can often lose their periods, amenorrhea. I think the biggest issue, though, are the cardiac. So you can get myocardial atrophy, sudden cardiac death from arrhythmias. You can get autonomic dysfunction as well. And then long term, you're looking at bone density loss, low estrogen. There are other factors too. You can get lung issues, spontaneous pneumothorax, aspiration pneumonia. So there's tons of health issues. And I would say that this particular disorder is very dangerous and can kill people.
Yeah.
So it is something that if you suspect somebody of having, or you yourself suspect, you should definitely talk to a professional.
Yeah, absolutely, absolutely.
And
And
can you speak to the death rates in
um,
this with
yeah,
this or?
not so much rates, but I mean just like Dr. Stansfield's saying there, this actually has the highest mortality rate of all psychological disorders.
Wow.
Yeah.
So
I-
it's dangerous, and that's not
Yeah.
kind of joking around. That's kind of.
Yeah. I think it's kind of a fascinating disorder
Mhm.
and that we are wired to eat, right? For survival.
Yeah.
And these particular group of patients actually overcome or are able to force themselves not to eat.
Mhm.
And in some cases actually die this way, right?
Yep.
And to overcome that basic human need, I think is from a medical perspective, kind of fascinating.
Yeah.
Yeah. Yeah. And there's also a higher risk of suicide with this population.
Yeah.
So their bodies are falling apart, their lives are falling apart, they're depressed and miserable, and so
Yeah,
suicide.
I'm glad we're getting all the aspects here because it's like you're giving us like the psychological aspect of what could happen if you're going through this. She just gave us like all the medical stuff, and I'm sitting here, I'm just like, well, you're definitely going to be nutrient deficient. Like you're not fueling yourself, so you're going to be nutrient deficient. But
Well,
Right.
that's the problem.
which will lead to all this.
Yeah, a lot of the cardiac arrhythmias, for example, are because of electrolyte
Electrolytes, yeah.
issues.
It's
So,
like starvation. I mean, isn't that part of what
yeah.
kills them, literally?
Yeah,
Yeah,
exactly.
yeah.
Yeah, exactly.
Yeah.
Can you touch on treatment for these group of people? Is it similar to binge eating disorders?
Yeah, some similarities. And again, on the good side, there's help. Yay. Now, again, the population usually, starts off, adolescent girls, up to young women, which can continue. It's unusual, for example, for a 40-year-old woman to say, "Hey, I think I'm going to start doing this." Uh, it's more likely that they started, somewhat younger. So again, even into adolescence. So there is strong support, strong research support for family therapy with adolescent girls, and the family therapy. Again, they're often in a proper program. They're multidisciplinary, so the family is going to be working with the girl and the nutritionist and the health person and the physician, etc.
Right.
They're going to be working with them to get some of the basic stuff, feeding, eating kind of things, while they're working on some of the other, behavioral and the fear-based stuff, the cognitive pieces, etc. But again, family therapy, great for adolescents. With adults, again, CBT, the cognitive behavioral therapy, and that's most often post-hospitalization. A lot of these women and girls, actually, they're good at hiding. They're good at hiding they wear clothing that doesn't make them look, as thin as they are. So a lot of people have no idea
Yeah.
that they're as bad off as they are until they end up in the hospital super sick.
Yeah.
I talked to someone last year actually who, just telling her story, um, did this off and on since adolescence into adulthood, and didn't get any help until she was almost dying in the hospital.
Wow.
And fortunately, for her, the physicians at the hospital were aware enough, going, yeah, you have
Yeah.
you have something else going on here. You're just not having organ failure because of organ failure. There's something else going on. So after the hospital, she went into an intensive program, and it was one of these, cognitive behavioral programs. So there's good support for that, for CBT. There's also good support for what's called, it's kind of fun, radically open dialectical behavior therapy. How's that?
Wow.
Uh,
It's a mouthful.
some people out there might know dialectical behavior therapy. It's called DBT. DBT itself was developed for suicidal patients who have borderline personality disorder. It's a very specific population. DBT has been expanded. It's being used kind of all over the place. So you'll see a lot of people talking about DBT for different populations. But this radically open DBT, it's a specific type of DBT, which focuses on again, a lot of this relationship stuff. So emotional expression, increasing social bonds with others, family members, friends, etc. Learning to respond to things in, again, a more flexible, not rigid, black and white, not rigid manner, but a more flexible manner. DBT itself, again, kind of the main way that it came out, is really essentially a mindfulness-based behavior therapy. So there's a lot of CBT sounding stuff that happens in DBT. It's very skills-based. We're learning, 5 skills this week to learn how to deal with this and this and this situation. Very relationship geared, and a lot of mindfulness, which is this focus on here and now experiences rather than, if you think about worry or anxiety, that's thinking about the future. Oh no, something bad is going to happen in the future. Depression is often thinking about the past. Oh, horrible things, happened to me in the past or something, and I'm sad about that. So with mindfulness, it's, present moment. What's going on right this second, and what do I need to do to deal with whatever I'm dealing with. Fortunately, also, well, with all these disorders, again, relapse is a pretty big thing. Relapse meaning they got better, they went through some treatment, probably they stopped or decreased considerably, whichever the behavior is, and then they kind of fall back into it. And again, just like we were saying earlier, one binge episode is not, binge disorder or something, or not eating today does not mean I have anorexia or something. So again, it's a pattern. But if they got better and then they didn't eat today, we might call that a lapse technically.
Yeah.
But the lapse turns into, okay, now it's a few days. Now I'm back to worrying about my getting fat again and blah blah blah. If we kind of fall back into the whole thing, that's when we call that a relapse. So there's several programs out there in different areas. Substance abuse uses this concept a lot, but the concept of relapse prevention, and there's a very effective relapse prevention program for anorexia nervosa. It's called Guideline Relapse Prevention, or GRP, for anorexia nervosa. And the research on this approach, and it's a pretty specific manualized sort of approach as a workbook for the patients and a bunch of good information, cuts the relapse rates by 2/3 or something. It's really good. And the researchers who put this out there, it's a Dutch team. They have a website, and they said, "Here's our stuff. Here it is."
Wow.
I can
That's
share
great.
the website or the manuals with you later. But they just have it out there. Hey, here it is. Use this and get better.
Wow. That's cool.
It's designed, ideally to work with a therapist or some kind of provider. And there are even kind of family components to it. Again, there's a lot of this relationship stuff. But that's to help the person, because again, if you had a day that you didn't eat, okay, that's a lapse. We want to prevent relapse. Again, relapse prevention. So here are a bunch of things that you can do to stop, to just halt that full relapse from happening. Here are the tools. Here are your steps. Blah blah blah. They have them work it all out, and that kind of focused approach. Again, really, really helpful, really effective. So again, good stuff out there.
Yeah.
We want to know where to get it and how to get it.
Awesome.
Yeah.
Well, there's 2 more that we want to touch on. One of them we really want you to dive into. So let's go into that one, which is bulimia. So can you also start off with discussing the diagnostic criteria?
Sure. Yeah, bulimia, and again, we're seeing with anorexia, there's this binge thing with binge disorder. Of course, there's the binging. So with bulimia, now we have these, again, recurrent episodes of binge eating, and binge eating here is looked at as some discrete period of time, usually a short amount of time, where again they're eating more food than is typical, than is usual, etc. And they again have this lack of or sense that they have no control over their eating, okay, during that episode. So I'm eating more than I need to, and I, again, have no control over this. Um, Along with that, they're engaging in these what we call inappropriate compensatory behaviors. So they're trying not to gain weight. So they're doing, again, maybe vomiting, misusing laxatives or diuretics or other medications that could be used, or they're fasting, or they're engaging in excessive exercise. So again, all these things to kind of control their weight. So they're eating too much, feeling bad, and then trying to do this other stuff to somehow control it. Um, the binge eating again is about at least once a week for 3 months, and similar to some of these others, they're still seeing themselves in a distorted way. They don't like their body. They're not fearful. There's not that same anxiety with anorexia about gaining weight, but they still are judging themselves. I'm not good. I don't look good. Something's wrong with me. This kind of judgment stuff. One of the differences, and again, we said with anorexia, there's also this binging type, one of the subtypes. Um, One of the differences is that most women or girls with bulimia are normal weight or maybe overweight. Whereas again, anorexia, even when they're binging, they have the lower weight. That's one of the main criteria.
Yeah.
Um,
I would like to say that it's still dangerous on the
oh,
medical side. And they do get cardiac arrhythmias, hypokalemia.
yep.
And if they are throwing up, obviously they're going to get dental erosions. There
Mhm.
can be a lot of esophageal issues, GI issues, electrolyte
Yeah,
issues. So it's not, um, so even though it might not be reflected in their weight, they might look a healthy weight, for example.
right. Yeah.
There's still
Mhm.
definitely some medical issues with this disorder as well. So
Definitely. Yeah. And again, a lot of times, just like you're saying, they're caught by all these other providers. It's the dentist catching them saying, "Hey,
yeah,
Yeah, wait a minute.
yeah,
what is this?" Or again, they're complaining of, "Oh, my throat is always sore," or something. They're having these other kind of speech problems or something, and so when they talk to certain providers, they'll go, "Yeah, something's not right there."
Yeah.
right.
Um, so
Yeah,
that's how it
definitely.
comes in. With this one, again, strong research backing once again for CBT, okay, that cognitive behavioral therapy. Um, Again, focusing on the same stuff, the distorted thinking about what's going on, their thoughts about um, having no control. I have no control over myself, and I don't look good, and those same sort of things. The behavior, of course, the binging behaviors and the purging behaviors. So they're going to be using strategies to to decrease both the binge episodes and the control episodes with the exercise or etc. And again, in a good multidisciplinary program, the health person, the exercise person, the physician, they're all going to be working together on all these pieces. Okay, hey, exercise is good, right? We should all exercise. But here's how we're going to structure. Again,
Yeah,
it's
yeah.
not
Right. It's
crazy.
not extreme. It's not the
Yeah,
all or nothing
all or nothing again,
mentality.
right?
Yeah.
Exactly.
That's interesting. Yeah.
Um, one of the things to watch out for with this group is that suicide risk is a little more elevated.
Interesting.
So yeah, so we want to watch out for that. Sometimes sometimes suicide might be the presenting thing. Hey, here's a person and they're in crisis, they're suicidal, and we always want to deal with that. There are ways, actually, CBT again, um, treatment to get someone off the ledge, so to speak. If they're suicidal, let's get them to a stable point. And then oh yeah, hey, all this other stuff is going on. All right, now we have this other more focused work with the specific eating disorder.
Mhm.
Um, Again, like we were talking about at the beginning, same thing. A lot of depression, bipolar disorder, some more substance abuse you see with bulimia patients compared to the binge eating or the anorexic patients.
Hmm.
So that's something else. Drinking or drug use. Again, trying to control their feelings, their experiences, and or their weight or their appearance.
Oh,
Oh,
that's interesting. Is there a reason for that, or have they?
Um, well, they're theories. I don't.
But nothing. It's just mostly an association. Like these people
Yeah,
seem
yeah.
interesting. Yeah.
So,
Well, that's, I think that's all the formal eating disorders we have. I know a lot of our population that we work with,
mhm.
we've heard of the term orthorexia nervosa, which is not in the DSM-5.
yeah,
It is not a real diagnostic disorder, but I came across it as a competitor, and
Mhm.
basically it's this belief of you have to eat healthy, or my favorite one is you have to eat clean.
yeah. It's clean
Um,
eating or pure eating, right?
yeah,
Yeah,
Like
yeah.
nothing bad at all can go into your mouth.
yeah. And I feel like to me it seems like there's a little bit of an obsessive component to this, and that these people seem to obsess about only eating healthy foods.
Mhm.
And so I wonder if it's um, a matter of time before there's an actual formal category for this. But have you heard of this, or
I've just heard a little about it actually, not a whole lot, and even in the psych literature, there's not a whole lot out there yet. So
mm,
it is interesting. Yeah.
more to
Yeah,
come for
yeah,
sure.
yeah. I
Yeah.
mean, you see it a lot in the competitive in that
Yeah.
field, just
Right.
because it is like they believe that you have to eat a certain way, and like we try to push the narrative to where there are no clean and dirty foods.
It's
Like
also
food
that
inherently,
extreme eating, like the bad
Right.
foods or the good foods.
yeah,
Like it's that extreme thought process
yeah,
again.
yeah. And we try to push that narrative to where it's like there's no good or bad foods. It's like food inherently isn't bad for you. It's, how much are you eating of it and how often do you eat it? Like
Yeah.
focus on foods that show love to your body more often than eat foods that don't show that much love to your body.
Mhm. Yeah.
And that can help with restriction. But when you encounter these people, a lot of them, their minds are made up. Like there is no telling them one way or another. And
Right.
I'm going to be completely honest, like working with them as clients, they're terrible clients. Like they think they know more than you when you're the
Yeah.
expert. They want
Yeah.
to tell you what they should be doing. It's like, why'd you come to me for help then? Like,
Because my
yeah.
life is falling apart. Well, okay.
Yeah, yeah,
Well,
Exactly.
that's
Exactly.
something.
yeah.
Yeah, that's fascinating. And yeah, I'm not sure when this episode is airing, but we're entering into the Olympics, and I'm sure if we dug around,
Oh
you know,
yeah.
into
Yeah.
Olympic athletes, we're going to find all this stuff: the orthorexia, the bulimia,
Yeah.
etc.
Especially with the
Yeah.
gymnastics.
Yeah.
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 Starts at a very young age with
Yeah.
them is what
Yeah.
I've seen.
Yeah,
Yeah. Yeah.
it's
Yeah.
interesting stuff. But again, there's just like you're pointing out, and with all these, it's the rigid versus flexible thinking and behaviors, and
Yeah.
that's what again a lot of the psychological treatment tries to help people be more flexible. And just like you're saying, there's no bad anything. There's no bad food. Um, I say, well, yeah, there's nothing wrong with a donut, right?
Yeah, yeah, yeah,
Yeah.
exactly.
Yeah. Right.
Or
Exactly.
Right.
even in the substance abuse field, well, there's nothing wrong with a drink. There's
Yeah.
nothing wrong with alcohol necessarily, but our patterns of using it can be unhealthy and certainly can have negative impacts on our lives. And so again, it's the same thing with what are we doing? How are we dealing with it? How are we approaching it? What is our mindset to this this thing I'm using here?
Yeah.
Yeah,
So
fun
one
stuff.
one one real final question that I want to ask you,
Yeah.
which I think is going to be very relevant. Number one, if there is, like, for our listeners,
Mhm.
someone who might feel like they're dealing, like they might have it but don't know where to go, or maybe a nutritionist or a coach that's listening to this sees
Yeah.
a client that's, showing some signs and maybe is concerned, what should they do? Like who should they reach out to, or what do they Google search? Like what's the steps on what they should do in order to get some help?
Yeah, great question. And I'm guessing a lot of your listeners are kind of all over the country a little bit. Um, Probably most people, if they're working, or someone in their family has a job and they have health insurance, I encourage folks, hey, contact your health insurance, contact your insurance company and say, hey, who do you have that specializes in whatever eating disorders.
Mhm.
And the insurance company should be able to say, okay, great, you're in this area. Yep, here are 5 names, here are 6 names, etc. So that's always kind of the easiest first place to start.
Mhm.
If you want to be a little more creative, most states and also some larger counties will have psychological associations. So we're in I'm in the state of Utah, so the Utah Psychological Association. If you go on their website, there's going to be a find a psychologist, kind of a search function.
Yeah.
And you can go in there and say specialize in eating disorders, blah blah, blah, and boom, punch up there. A bunch of names come up. I helped a fairly elite high school athlete recently who wanted a sports psychologist for some help, and
Oh,
I
nice.
knew the person, so I couldn't work with her myself. Um, so I said, yep. And I brought her to that website. Hey, check it out. Here we go. Let's find someone. We pulled up several names, 2 of the people I knew personally. I'm like, hey,
Yeah,
great. I
that's
know this
awesome.
lady.
Yeah.
She's
Yeah.
fantastic. Let's give her a call. And called up and found someone pretty easily, actually.
How do they know if if they're like actually like good
Yeah, I know.
at what they do? Is
Uh,
it kind of just like trial and error?
uh, Probably.
Read
I
reviews?
don't, I'm not. I know my kids are review fans. They look up people and all this stuff.
Yeah.
I don't do that, but um, I mean, some of their, because these days, if you find someone like that, again, from your insurance companies or on the, psych website or something, yeah, they probably have a website, themselves for their clinic or their agency, whatever, and a lot of them they'll have a bio, and usually
Mhm.
if they're good, they'll talk about their specialty areas, and a lot of the even better ones, of course, will say, hey, I do CBT for bulimia. It's like, okay, good. That's
Yeah. That's
probably
specific. Yeah.
Exactly. Yeah.
Very
and a lot
specific.
of them, again, if they're sharp with that stuff, they're going to be specific with the types of treatments that they do.
Yeah.
Mhm.
So that's something. Um, Again, I'll send you some links maybe if you want to put them in
I'll put
your
them in the show notes. Yeah.
short notes. Um, a couple things. There's it's actually run by the government, a fine treatment website where, again, same thing. You type in your city or your zip code, and you can click on whatever, mental health or substance abuse, whatever, and it gets pretty specific. And again, boom, you'll get sometimes 20 names of people.
Yeah.
So it's
Nice.
nice.
Yeah.
And I'll also give you a couple websites that are interesting. They are lists actually of, again, the kind of more effective treatments. They're
Nice.
pretty specific. One's for kids, and again, the eating disorders start off when they're kids, so
Yeah.
that's a helpful one. But one's for kids, and then one's kind of more in general for adults. But you could type in, symptoms or diagnoses, whatever, and you'll get a readout on, yep, this one's effective, this one's okay, this one's modest, this one's pretty good. So you have again a little more information, a little more know-how on what's out there. Again, a lot of people, because like I said earlier, there are hundreds of treatments out there. Some of them are, again, kind of fringy. And they'll argue, hey, but mine's good too. There's just no research on it.
Don't go for
Yeah.
that.
I know.
No.
Kind of sounds like functional
Physician,
Yeah.
practitioners.
our physicians have certain opinions about that kind of stuff.
Mhm.
So do we. So, it depends on how risk averse of you are or not.
Yeah.
But again, there's the good thing, I'll keep saying it, is that there's a lot of good help out there, a lot of effective treatment. We want to get people to the right place. That's for sure.
Yeah.
Great. Well,
Awesome.
yeah, Dr. Mark, thank you so much for coming on and giving
Yeah.
us all this knowledge. And I will definitely put those websites
Sure.
and those links in the show notes. I
Yeah.
really, really think this is going to help a lot of people.
Awesome.
Yeah, thank you
All
very
right.
much. We
Yeah, well,
appreciate it.
thank you too.
So, on behalf of Balanced Bodies, we just want to say thank you for joining us on this episode of the Balanced Bodies Blueprint.
We are committed to bringing valuable content. And if you enjoyed today's episode, we'd greatly appreciate it if you can take a moment and like it and leave a 5-star review.
On Apple, just go to the show, scroll down to the bottom and rate it there. If you're on Spotify, go to the show's page, click the 3 dots, and you can rate it there as well.
And if you believe in the power of knowledge, share this episode on your social media to try and get the information out there to as many people as possible.
And as you navigate your own path towards better health, remember that Balanced Bodies is forever in your corner. See you all next week.
The podcast content may include discussions of medical topics and health-related information. However, the information provided should not be considered exhaustive or complete, and it should not be relied upon as a substitute for professional medical advice or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition or treatment.